everybody. My name is Amgad. I am one of the mentor in the FRCS mentor group. Our talk today is about starting structure approach to FRCS short cases. And I actually kind of modulated this in a way that it's very FRCS focused regarding the short cases, because there are a lot of difficulty, and we found that the difficulty is mainly around the short cases in the exam. I have Osman, he's my colleague there, and he's one of the senior mentor in this group. And I have Mustafa, who's modulating the session. And we will start the talk shortly. I would just encourage you, if you have any question, to raise the question, raise your hand, or you can write the question in the chat box. And a bit of housekeeping, it's actually crucial. And this is an approach, I did this exam is about 3 times. And this approach, I developed this approach through going to a lot of courses, through a lot of teaching sessions. I benefit a lot from this group, actually, from the mentor group. And there is a lot to take in this. So my approach to this is a very kind of different way. I don't think this is the only way of doing this, but it's a good way to summarize things and to get the maximum benefit out of this. So I'm based in Dublin, in Ireland, and actually I work in a hospital outside Ireland, about 20 minutes from Ireland, from Dublin. It's called Navan Hospital, and it's a small hospital. It's like a DGH. We do most of the elective orthopedic work is done in that hospital. So regarding the disclosure, I don't have any financial disclosure, and these are all my thoughts. I did this presentation on my behalf, and I got these images. There are a couple of images, either from friends or from multiple sources from the internet. I got it for free. And I would like to thank Osman, and I would like to thank Mustafa for modulating this session. So as I mentioned, this is an FRCS focused approach to short cases. And I tried to do upper limb and lower limb. I found it's gonna be very lengthy. So I concise it into the upper limb, and then I will do the lower limb later on. There is 1,000 ways to skin a cat, but this is my way. It might be suitable for some people, it might not. So you need to find your own way and develop it. The most important thing is to remember, this is just a game. And the more you play this game, and you play by the rule, or you bend the rules, anyway, once you play this game and you get good at it, you enjoyed it. You find this is really fun. Let's play this game. And my approach to this is, number 1, to be very quick. Time is not your friend. There is no time wasting in these short cases. The short cases will come at 5 minutes. And if you count it, by the time you get the examiner to get you to see the patient, it's actually about 50 seconds or like 1 minute, it's gone. So you have 4 minutes. So you have to be extremely quick. And it's actually, they used to do it as spotters, but now they change it as there is a rapport between, like there is no rapport actually, but there is kind of, you can introduce yourself quickly and then go, it's a spot diagnosis. So the key here is to get the diagnosis, give the diagnosis early. If it's a Dupuytren, say, this is a Dupuytren. If it is you can see trigger finger, you say, this is a trigger finger. You can see cavus foot, say it's a cavus foot. So once you say the diagnosis, you are on the path, like 5, 6. And then sometimes you might need to have a system. having a system to enable you to reach that diagnosis. And I will go through this in this presentation. Once you reach the diagnosis, you change it to a Viva. And that's the magic of doing this. Once you change it to a Viva, you are gonna be winning here. So the Viva, you're gonna be talking about the clinical scenario, and you're talking about then the management. All people, you will know that you notice that all people who have this change to a Viva, they are really happy. And then you can win the round by showing the evidence, and this is where you get the 7s and the higher marks. Okay, so this is the way of doing this. So I feel the analogy I use is that like this is like a magic show, and people like the kids are really kind of very fascinated with this magic show. But once they know the trick, everything is finished. So the magic show is over. So it's once you spot something, you zoom your, like for example, you find this rupture of the distal biceps. You find that, that's it. Zoom your diagnosis, finish the examination very quickly, and say it. This is a case of distal biceps rupture. Or if you find this APL rupture, okay, say it straight away. Okay, if you find the median nerve, whether it's a proximal or distal median nerve palsy, you say it, and then you zoom your diagnosis, and you finish your diagnosis, and then the examiner, if there is another diagnosis, the examiner will take you through that diagnosis. And this is how you do it. So let's get started. So, sorry, don't look miserable. You need to be looking smart, you smile, you're ready for action, and look around for clues. The clues are always there. They're hidden. Sometimes they hide it. They hide the clues for a reason. They just want you to look for the clues. The clues might be splint, might be like very obvious, or might be very, very subtle. But you have to look for the clues. You need to know your anatomy very thoroughly. This is a no mercy game. If you don't know your anatomy, you're not gonna win here. If you find the case of feet, you need to think spine. So most cases of especially cavus foot, you need to think spine. All cases of if you find like clubfoot or any foot deformity, I would be thinking of spine. If you have another case of feet, you need to and there is a deformity there, you need to think of the hand and rheumatoid hand. You will know rheumatoid hand straight away. You will not know rheumatoid foot if it hit you in the face. So it's very easy to look around and see if there is rheumatoid hand, and that will be easier for you. Anticipate the short cases. You need to anticipate, where is this coming from? Well, like, and where is my kind of buzzwords? So cases like neurofibromatosis, what are the buzzwords for? You need to be thinking of, once they say neurofibromatosis, there is NIH criteria. I need to rattle that NIH criteria quickly. So there is a lot of takes into these short cases. And the trick is to get more and more practice. That's how you get a slick on it. Offer explanation and to avoid prompting. So if you see something, you see, like, for example, this is ulnar clawing, okay? Once you see clawing, you say, okay, this is clawing because of the involvement of the lesion, ulnar paradox. For ulnar clawing, you need to mention ulnar paradox, because ulnar paradox, the more distal the lesion, the more severe the deformity. And this is important because the examiner will be at ease there. So this guy knows what he's talking about, and leave it as a very clear, crystal clear concept in your mind. Opposite to what we think, nerve injury, the more proximal the lesion, the more severe the deformity, or the more severe the injury. But in the ulnar paradox, it's the opposite, okay? When revising the big conditions, think of what I need to know and what I need to ask about, and make a list. I think there is a presentation in this group by my previous mentors. There is one by Damo. You find it in the YouTube, and it will list of the condition that you will see in the short cases. So I won't kind of go there. The key is to practice, practice, practice. It's like a marathon. If you don't practice, you're not gonna win this marathon. Okay, so you need to practice. You practice with your colleague. Practice with you. The best thing, if you can find a consultant who's interested in teaching, that will be the best thing. And the best thing I found when I was doing my exams is that I went to a morning list for my consultant. One of the consultants was very keen, and I went into the morning. So all the cases were there, ready. There are signs there. So these are real patients. So I went through 4 or 5 cases quickly. So the examiner was very good, or my consultant was very good, and he helped me a lot. But sometimes I can't find it. I will do it myself. I do it either in the clinic. I set the clock for 4 minutes, and then I practice on the patient. I say, listen, I'm going to do my exams, so I'm just gonna stick with time here, okay? Practice is the key here. And that's how you are going to be looking slick, by practicing with your wife, practicing with your friend, with your daughter, your son, everybody. Things that you are going to forget. This is the things in my mind. I always make sure that I'm not going to forget. Girder stone. If you see a scar and the joint is not moving, you have to think of fusion, whether it's a shoulder, whether it's a knee, whether it's a hip or elbow or wherever. You think, if there is a scar and the joint is not moving, this is fusion, and let's prove otherwise. The picture on the right is polio. Polio, I kind of was always thinking of polio, and in the polio there is a clinical presentation that you need. Sensation will be like the limb has a deformity, but the sensation is normal, so it's a motor deformity. And this is where you need to pick it quickly. So then the case will change to a viva. And it's once you change it to a viva, you are winning. It's a quick, and you're gonna get the higher marks. Now things that you need to be aware of. The days that the short cases are straightforward are gone. No, sometimes there are things that you give you Dupuytren, but they have carpal tunnel. They give you Dupuytren or nerve pathology or tendon rupture, and that's actually, it happened to me in the exam. My case was Dupuytren, and it has EPL rupture, and the other one was one of the guys got it. It was Dupuytren. Actually, in a previous exam, I got Dupuytren with high median nerve, with proximal median nerve injury. So you need to be wary of when especially if the Dupuytren is very subtle. So you don't have the full Houston tabletop, the full flexion deformity. If the Dupuytren is subtle, think of a double pathology or something else. CMC joint with carpal tunnel, we know that there is an association of 48%. So once you see CMC, say, listen, I'm going to say this is 48% about this have involvement of carpal tunnel. So the examiner will be at ease, and you are going to be winning here, because the examiner knows that this guy knows the stuff, and he's happy to crack with you. Trigger finger, carpal tunnel, rheumatoid hands with tendon ruptures, and elbow. Always in the elbow, you have to examine the ulnar nerve, and the ulnar nerve usually is you check for even just for subluxation, or they check the full ulnar nerve. You offer this. The time constraint is very short, so you need to. If you mention it, that's a box ticked. So this is how you. There are a few catches, and we will know how to deal with these catches. The first one is drop wrist. You can easily miss it. Drop EPL rupture, easily missed, and they love it. So the hint or the clue might be a splint, might be might be a scar, or so these are the scars that sometimes the scars in white people heals very well, and you might miss that scar. And so sometimes the scar is for tendon transfer, so there is weakness, but you can see a funny movement, so you need to be wary of that. Drop foot, you can easily miss it. Myelopathy, these are the things that you need to be aware of and keep them in the back of the mind. I'm kind of fascinated by the concept of 360. You need to look around, because everything is in that look. Okay, the deformity might be very obvious. You can see it in front of you. There is leg length discrepancy. You can see it from the next room, or that shoe raise might be seen from the next room. But it might be a stick. It might be a crutch, and the crutch in the FRCS, for some reason, the crutch, they leave it behind the door. They leave it behind the door, just for you to look around. Okay, now it can go. Actually, the orthosis that in that picture was, I got it in my FRCS, and it was for a charcot joint, and I got a charcot joint in the ankle, and sorry, in the foot, and I was at the first thing, they have a scar, and sorry, they have a dressing over that scar, and they didn't allow me to touch anything. So I said, okay, I'm just gonna look around for clues. And I spotted that orthotics, and then the discussion actually was about orthotics. And that, I think that was the case that I passed. So you never know where is the discussion gonna go, but be ready for everything. You see that there is a Ventolin inhaler. That can be a clue that this patient might be not fit for surgery. So these are the clues that you need to be wary of. I always have a problem when they ask me a question. They say, okay, come on, doctor, ask 3 questions, ask 1 question. This is where it gets hairy, will get very challenging. I prepare this question to challenge most of the cases, and I direct patients, or I direct the examiner towards to answer, direct answer. I know sometimes they can go around in circles. Some of the patients, they like to do that, but I just pin them towards what is the problem, when did it start, how does it affect you, and what treatment did you have, any medical problems, and what are your expectations. So this is always keep this question in your mind. If you are asked about few things, they say 3 questions, I say, what's the problem? How does it affect you? And what's your expectation? When did it start? Because you need to kind of differentiate between whether this is congenital or acquired. And that's very important for your treatment algorithm. We're going to start with few cases. I think the hand was one of the difficult, because I did about mass. So mass, I will explain this mass. You need a pillow. There is a screening. I'm going to explain all of this later on. So any hand cases, if you are faced with a hand case, get a pillow. That will really go down very easily. Get a pillow, and the examiners will know that you know your stuff. Okay, remember, always get a pillow. Okay, hand cases, get a pillow. Mass. So for the mass, you need to look for muscle wasting, attitude, whether it's flexion attitude, extension attitude, clawing, buckering, all these attitude of it. And then look for scars. Every scar has a story. Every scar has a story. And once I found it, they will always ask you about, what do you think this scar is? So doctor, what do you think this scar is? So I found it, this is the most challenging. So you need to be open-minded about the scars. You can describe the scar, you can get around it by saying, this is a mature surgical scar, most probably for blah, 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 okay? but don't commit yourself, because the scar can be for something different. Yes, the scar, every scar has a story. Keep it in your mind. Splint, I cheat, and I think this was, I think, permitted, like you have a permission to do some cheating there. Okay, ask actively. I will ask the patient, do you wear splints? Do you wear splints? Although the people, they say in short cases you are not allowed to ask a question. Actually, in FRCS, yes, you can ask, but don't make it as a habit, because they examine you for 3 cases, and they will kind of pick on this. So this guy is cheating all the time. But think about it, okay? Now, I start my examination by doing the screening. So the screening is very important, and I think the way I do this in screening is, I think I found that I can pick most of the hand cases by doing the screening. So open, that if there is any Dupuytren or any clawing or any nerve injury, tendon injury. Closing, and that will same again. If there is nerve injury, tendon injury, or any deformity, will reveal itself straight away. And very slowly, very important to do it slowly. Now, close and open, you have to do it slowly, because trigger finger might be very subtle, and you just, once you say like this, and that you find this finger is locked, and that's where the case might be trigger finger. If you miss it without the screening, that's it, that's game over. It's very hard to recover from it. Okay, now I used to get the thumb up to get for abductor pollicis brevis and see if there is any weakness on abductor pollicis brevis, and I flex the thumb for FDP. Okay, then the same thing on the dorsum of the hand. So do it on the palmar of the hand and then dorsum of the hand. Close and open. Same again. When you see any scars, any here, if it's the case is for example, rheumatoid, you look for these scars which are subtle. The case is, for example, ulnar nerve, you look for guttering, and all the other cases that you can pick easily on the dorsum of the hand. So then again, close and open. And then the last one will be thumb up, and that's for EPL rupture. You get caught if you don't do thumb up. And then look for the elbow for rheumatoid nodules. I found that this is screening technique is very important in picking almost 90% of the cases. However, sometimes you go screening and you can't find any finding. So what the fuck is going on? Sorry for my language, but if you don't know, you did the screening and you can't find anything, think of sensation. Okay, sensation is your friend. So I start straight away looking for sensation. I've divided this. I know that there is 100 ways of doing the sensation, but this is very particular for the FRCS. You need to divide the nerve into proximal and distal. All the nerve, you need to divide them proximal and distal, especially in the upper limb, okay, apart from the radial nerve. But, and be very particular, where are you checking the nerve? Very particular, because the examiner will be looking, where is your finger, where is your sensation, and compare it to the other side. That's the way to do it for the FRCS, okay? So distal, you check it for, it's called the autonomous zone, okay? So distal in the index finger, and proximal for the thinner, around the thinner muscles, okay? And you check and compare with the other hand. If you think that the other hand is involved, you check it in more proximal. But be wary, don't touch the patient without permission in the forehead or in any proximal area without permission. So you need to know how to play the game in a very polite and controlled manner. So, and this is all about the anatomy. It's all about the anatomy. So where is the I will know where is the proximal part of the median nerve come from, and where is the distal part come from, and what's the nerve supply for that, and what's the nerve supply for the distal part. The ulnar nerve, and as I was mentioning earlier on, you need to, so the autonomous zone is little finger and the dorsal cutaneous branch of the ulnar nerve. So I found that if you say that this is from the dorsal cutaneous branch of the ulnar nerve, and you say that like this, the examiner might not be very interested. But if you say this is a branch come off about 5 centimeters proximal to the wrist joint, this man knows the anatomy and knows very well where is that nerve is gonna happen, or nerve is gonna be injured. So you need to know. And then the radial nerve, as we mentioned before. So these are the zones, that the autonomous zone that you need to be aware of in the FRCS. Now, then the motor, I found it, there's a lot of motor innervation in the hands, and you can pick any muscle. The muscle that I found that you definitely need to know is that for median nerve, you need to know for abductor pollicis brevis, and that's the way to, this is their very particular way of examining the muscle, okay? So I will notice that the examiner will just kind of very focused, looking at you, how are you examining that muscle? So finger on the resistance and finger on the muscle belly as well. So to check for the power. And then you say it, you don't say, oh, it's okay. No, abductor pollicis brevis, 5 out of 5. The power is 5 out of 5. And that's how you classify it, okay? So then the FDS, and you need for the FDS, this is the technique, you need to stabilize the other fingers and then check. So this picture is not correct. The way I do it, I put resistance as well in the FDS and then check the resistance, and then say 5 out of 5 or 4 out of 5 or so, sorry. And then ulnar nerve. The ulnar nerve is very common, and the examination of the ulnar nerve might be a bit complex, but to make it very simple, once you do the sensation, the motor is, there are mainly 2 muscles. Distal, I would say the ferris dorsal interosseous is the most important muscle, and you see it straight away here. If there is wasting, you see the guttering of the dorsal interosseous, but you see it and you check the power. Then for the proximal lesion, you will check for the FDP of the ulnar. You can check for the FCU, but that's my way of getting this over and over again, so you can get slick and you can have a rhythm that you go on that system. For the radial nerve, you can check usually EPL or the triceps. There are loads of muscles, so you can check for the metacarpal, for EDC, you can check for the extensor carpi radialis or longus or brevis. The difference is that longus can give you radial deviation there, okay? And very important to differentiate between the radial nerve proper and the posterior interosseous nerve. So it's mainly, these are anatomy. These are always anatomy. And then even after all these, you finished and you will come to a rod junction. Now you need to commit yourself. You need to find a diagnosis. If you don't know till now, go to a surgical sieve, okay? Like, there are lots of things that if you go through congenital problem, if you go through neoplastic, so you don't know, there is either a tumor or there is a congenital deformity of the hand, you don't know it, go through a surgical sieve. Go back to be safe and get a differential diagnosis, and then you can say, they will take you through one direction. They will gear you towards one direction, and they will ask you then further. And that's where you reach a diagnosis in a systematic way. I'm going to go through quick examples. As we mentioned here, nerve compression is very, very, very common. These are examples for the short cases. This is for you guys. to practice on it. Practice on it. Okay, let's do the median nerve. Let's, okay. Remember mass, muscle wasting, attitude, and then splints and scars. Scars, splints. So muscle wasting, attitude, scars, splint. Muscle wasting, attitude, scars, splint. And then you go for sensation, you go for motor, and then provocative test, like for Tinel test. And you can, very important to do, the way of doing Tinel test is from distal to proximal. And this is the way I've seen it in courses, and this is the way being taught in by the guys who are put in for the exam, like Fazal Ali and Banaskovic. So this is the way to do it. Hands, do between rheumatoid, CMC, EPL, snack and slack. Elbow, and these are the list here. I don't need to go through each one of them, but you can find it, and it will be in the YouTube. Very important to do hand function. Hand function is crucial for the hand examination. I'm not sure this picture is accurate, or you know, everybody has his own nomination for the hand function. It's important to have it clear. There are 5 for FRCS. There are 5 hand function grips. 3 are precision grip, and 2 are power grips. Get this concept clear in your mind and get it right, okay? So the precision grip, like tip to tip, or you can say any some people say tripod, key, okay? So the key, the lateral pinch is key. And then there is, some people, they say the coin is a tripod. So there is differently. So key, pen, and a coin, this is the way to say. And then hook grip and power grip, where you hold the power. These are the 5. So it's very, like, if you're gonna go to the, always take a key, a coin, and a pen. And it's easy. You don't need to, some people, they say in the short cases, will I take a measure? Will I take, actually don't take a measure, because you are gonna dig a grave for yourself. Do not take a measure. Yeah, maybe you can take a torch pen, and it might be a nice thing to take a torch pen, because that pen will be a torch pen, and it will be a very good to, if you get a ganglion and you can get a trans illumination, that's a bonus. But it won't save you from getting the principle right, okay? The concept right. You need to describe, you can't jump from the very beginning to transient illumination. So you need to be thinking clearly there, okay? Nerve compression, these are anatomy and physiology, like either anatomy, you need to, once you get a nerve, they're gonna ask you anatomy, and they're gonna ask you where this nerve is compressed to give you this picture. Okay, so it's either proximal or distal, and there are sites of compression. You just go and read it and learn it by heart, because this is very important. There are 5 and I think 6 nerve compression sites. You have to learn it by heart. I don't care which way you do it, just learn it and get it out there, okay? And then it will be nerve conduction study. The nerve conduction study is a physiology or a basic science scenario, but it can come into short cases. And I've seen people, they get into the nerve conduction study. The final answer, once you find the nerve, like median nerve or ulnar nerve, it's about the tendon transfer. There are principle of tendon transfer. You need to know all this principle. I have a nice way of changing it. Instead of the 9S, supple, synergistic, and all these S's, you can change it to donor factor, recipient factor, and then just let me remember, donor factor and recipient factor, and the patient himself, like the patient should be motivated and able to do the rehabilitation. So donor factor, recipient factors, and then, so the donor factor, you can say that they should be synergistic, and all the S's, and the joint should be supple, and just single and same line full on all these kind of things. The recipient should be clear of infection, and then the patient should be able to understand the rehab and compliant. Now, this is where we come to the flashcards. Okay, so we come to the flashcards as all cases, case by case. You have 5 minutes. So 1 minute is gone. Hello, how are you? And stuff like that. And then thank you, goodbye. Okay. So you need to be, it's 4.5 minutes. Or so you need to, from the very beginning, there's a spiel you need to be ready for. Okay. For all the cases, you have this spiel, okay? So this is a hand. I can see that there is a flexion attitude of the right hand consistent with two-between contracture, okay? There is a cord, there is buckling, there is all these. Say as much as you can and keep talking, and do not stop until you get to the feel that you are satisfied that you describe the deformity, and then you can go. Some people, they say, here, you go for a screening. I would actually go for straight away. If I see the Dupuytren, remember earlier on, it's like a show, a magic show. Zoom. I seen Dupuytren, I'm gonna zoom towards this Dupuytren. I'm gonna go for cord hunting. So I see whether there is a commissural cord. That's important because it will indicate there is diathesis. There is a abductor digiti minimi cord, and this is all important. I will straight away ask the patient, okay, do you have it anywhere else? You're allowed to ask this because this is part of the examination, and it's very important to see and to rule out the cases because the management will be different. Okay, now FRCS examination, you need to flex. You show that you flex the PIP to assess the extension of the flex the PIB to assess the extension of metacarpophalangeal joint, and flex the metacarpophalangeal joint to assess the extension or the flexion deformity of the PIB joint. And if you don't do it in that way, you're not getting the full mark there. You can say, or whatever it might be hard sometimes with the deformity, but you need to show them that you are flexing the metacarpophalangeal joint to assess the proximal interphalangeal joint. You are flexing the proximal interphalangeal joint to assess the metacarpophalangeal joint. Neurovascular status, digital Allen test. And there is a way, I cannot do it on my own. There is a way to do the digital Allen test. And then, as I mentioned here, ask for diathesis, do the functional assessment. If you have time, we went through this, you can say, listen, I would like to do quick screening for other pathology, because they will say, no, we want you to go focus on this. So then this is a case you need to, at that stage, it will be 1.5 minutes. You need to say, this is Dupuytren, and then change it to a Viva. So the Dupuytren, you need to talk about family history. You need to talk about genetics, Zybex, and you need to talk about all the other scenarios there in Dupuytren. And the money is in the management. The money is in the management. So as long as you get to the management, you get to the management, you're passed, okay? And then you can talk about the evidence, and this is where you get to 7 and 8. Now, for the CMC arthritis is very, there is a spiel there, shouldering, hyperextension of metacarpophalangeal joint. Why? Is offer explanation to increase the span, okay? So because the sum is the metacarpophalangeal is adducted. So in order to increase the span, they will abduct so they hyperextend the metacarpophalangeal joint. So because the metacarpal is adducted, so they do this, okay? And then, as I mentioned, once you see this, you got your pillow, seen this, give the diagnosis straight away. Go for your screening. Grinding test, do not do grinding test in this case, because everybody, and actually it's nicer if you say, I would not do grinding test because it's painful in this. So that will show that you have empathy and you're very smart. Same, you stick to the look, feel, move, and you can do your functional assessment. Remember, 47% has carpal tunnel. So it's really nice to say it. They will say, oh, okay, move. But if you don't say it, oh, what do you want to assess anything else? You will ask you, then they will start to be, you will not know it, and you'll start questioning yourself. Did I miss anything? Did I miss anything? It's mainly, they know this, they're looking for this. And then you go for the, if you change it to a Viva, straight away, you change it to a Viva. So you're talking about Dias paper, you're talking about so trapeziectomy. I would not go. I will go from non-operative treatment, which is cup of tea, steroid injection, and then splints, and then I'll go straight away to trapeziectomy. I'm not going to go for anything else because the evidence is out there. Okay, and it's nice to talk about the evidence in this case actually. Now the catch. I got caught in this, and actually it was not this obvious. It was very subtle, and actually I got prompted, not in this exam, in previous exam, and where I flunked, but I got caught in this because it was so subtle, and then I had to. The examiner prompted me a couple of times, and then eventually I found it. So that screening for the hand is crucial to spot this case. Okay, so once you screen it and do it slowly, open it slowly, and you'll find the difficulty, the catching, and that's then you zoom your examination. You find that okay, this is a trigger finger. The management is so easy. It's so easy. Look, then you do the functional assessment. So remember, when you are reciting with your friend, when you are revising with your colleagues or with anybody, do this. Number one, flexion attitude of the finger. I'm going to do the screening. This is trigger finger. Look, feel, move, and then you assess the nodule, digital Allen test, and do the functional assessment. And these are the things that you need. So eight station in your mind in about 2 minutes. You need to do this this is how slick you need to do this. You need to do it every single minute. And you need to think of it. You need to think of it all the time. Now, this is a very common case in the exam, the ulnar nerve, and you need, as I mentioned before, you need to talk about ulnar paradox. So I'm gonna to give the diagnosis, and then sensory, motor, and then provocative. Froment test. You need to explain in the Froment test because the FDP is sorry, not the FDP. The adductor pollicis is not functioning. The patient is recruiting the FDP so you can see the finger, the thumb is flexing. So because the adductor, you ask the patient to use the adductor pollicis, but they cannot because the adductor pollicis is not functioning because adductor pollicis is supplied by the ulnar nerve. So to compensate, to offer this explanation. Don't wait for the examiner. You say why he's doing this. Okay, offer it. That's how you prevent prompting. Prompting is bad. Prompting is a killer. Prompting will cause you less. And you can see somebody sent into the group. There is a way of marking the marking sheet. The more you get prompting, the more you lose marks. Okay, it's anatomy question and then nerve conduction study. Sorry. Now, rheumatoid hand, actually, rheumatoid hand is easy, and it's really, it's like a gift. And the way I find it is it's about rheumatoid arthritis treatment. You don't touch this patient. You do not touch. Try not to touch this patient. And that's the trick. If you try to, you're fired, you're gone, okay? It's all about description. There is a spiel, you need to say it. There is bilateral symmetrical deformity of the both hand consistent with rheumatoid arthritis. And that's the way I say it all the time. The bilateral symmetrical deformity of both hands or both upper limb or lower limb or consistent with rheumatoid arthritis, start describing from this from proximal to distal, okay? And then you can do your screening. Straight away go to the functional assessment. Straight away go to the functional assessment. If you don't have anything to say, go to I say, listen, get my coin, my key, my pen. Rheumatoid is sorted. That's you pass rheumatoid arthritis, okay? But it's nice to have that spiel, okay? Causes of drop finger. These are the catches. Causes of drop finger, there are 4 causes, multiple pathology. What are the causes? How are you going to do it? I'm not gonna say it to you guys. You're gonna find it and search it and you find it. What are the causes for drop finger? So these are the bullet points that you need to go with, okay? You start describing the deformity. Don't think that you are gonna touch this patient, okay? Do not touch this patient because the skin is paper thin. The examiner are kind of nervous. There are a picture of, if you Google rheumatoid scars, you find like about 12 scars, either for replacement or for fusion. It's straight for, like if you find it, longitudinal scars are for fusion. If it's transverse scars, usually are for replacement, fusion of the wrist. But there are scars that you're gonna be very vigilant for kind of pointing this scar. You have to look for them. Now, the difficult one, oh my God, okay, I don't know what's going on. It's actually a gift, and they want to see you have a system. They want to see that you are gonna stick to look, feel, move. And then, if you don't know what's going on, and the deformity is so severe that you just say, listen, I'm gonna do functional assessment, and then I'm gonna go back to my surgical sieve. This is more than likely congenital deformity of, so the picture is either radial club hand, or this is what's you can describe, it's a viva. So change it to a viva. And that's how you approach it. And this is the lower picture is
multiple flexural creases on his elbow. One was operated on, the other one wasn't. And he had dysmorphic faces and neck as well. So I got really phased out, but then I kind of, somehow my mind clicked and I just went, it's some kind of syndromic anomaly. I don't know what it is, but I'm going to do the functional assessment, and I'm going to discuss this with my pediatric colleagues, and I'm going to involve my geneticist as well. This needs to be investigated, and it needs to be in a specialized center where I've got the expertise and the resources to deal with this. So if you got
so you change it to a vibe.
Get out of jail card, just keep calm, describe what you see, the deformity, what you see, and just be frank. Tell them it's a syndrome. I'm not aware of it, but this is how I'm going to go about it. And that's it. That's what they want to hear.
Exactly. You have a system and stick to the functional assessment, change it to a viva. Yes, let's go talk about viva. There are differential diagnoses, and that's how you approach this. Wrist actually is the same as hand, but I usually in the wrist, I change the rhythm of my examination. I'm gonna look, move, and then feel. Just that's a personal preference. And the same for the elbow, okay? So, but you need to be conscious of that. The wrist has 3 zones: radial, ulnar, and central. And this is how you differentiate between the problem in the wrist. And this is a question of anatomy and pathology, okay? You can get a cane box disease, you can get a snack, all the wrist arthritis or anything. Just you need to divide it. Where is it? And this is how you approach it. Quick range of motion examination, and that you can screen with that, okay? And that will bring you down to where is the problem. Elbow again, quick and easy. And I like elbow. And you know what? In the exam, there is a lot of elbows. There is a lot of elbow examination. and especially arthritis, rheumatoid arthritis. I got my rheumatoid arthritis in not this exam, in the previous exam, and it was my long case, but some people, they examine it as a short case. And elbow is very important. Do not forget the ulnar nerve in any elbow examination. Do not forget it, because you are doomed to failure if you forget the ulnar nerve. It's really important. Keep it in your mind. This is how you put your flashcard, is just carry an angle, you comment, carry an angle from the front, from the side, from the back, and then look, move, and then feel. Move. Yeah, put your hand, like spread your hand. So extend it, flexion. Do it actively and passively. Very important to do it passively as well. So because, yeah, you say, okay, let's see it active, and then, okay, can we improve it? Watch for the patient for the pain, okay? Then assess the stability and neurovascular, and then the joint above and joint below. These are the usual routines.
You guys can get, I'm sorry, Amgad, I'm interrupting you again, but with the elbow, you guys can get a flail elbow. You can get a chronic radial head that was excised, which you cannot feel. Osteoarthritis and rheumatoid in the elbow. These are very common. I also
screen, if you are stuck for time, just ask the patient, can you reach your mouth? Can you reach your bum? And can you put, that's a quick way. I've seen it in courses, and I found it really very handy, and I found this is very helpful to get. So as I mentioned earlier on, spread out your elbow, and then active and passive, and supination, pronation. And this is actually the picture, or the photo on the left is actually for the examination of the ulnar nerve, but you need to check for the subluxation of the ulnar nerve as well. So move it if it's sublux or not. And the examiner wants to see that all the time. Regarding the shoulder, I went from distal to proximal. Sorry, this is the easy way of doing this presentation. Shoulder, if you go to the short case, the first thing notice it is the age. Okay, the age of the patient, because younger patient are definitely instability, more than likely is instability. Older patients are arthritis or rotator cuff, and the one in between are impingement. So we know that, and this is everybody, this is for FRCS, 3 groups. Younger patient, instability. The minute you say instability, you need to mention Baton score and do it, and make sure that it's very, very easy to forget Baton scores. The minute you see a young patient, you more than likely you are going to get instability. Make sure in the back of the mind, there is Baton score. You're going to ask about Baton score, and you have Baton score already in your mind there. Okay, older patient, probably you are talking about we are talking about rotator cuff or arthritis of the shoulder. So, and it's strange enough, we got a case in our exam. Actually, I got it in my exam. It was actually frozen shoulder. So anything can come up, frozen shoulder, reduced external rotation, and that was one sign. So if you have this, you have to keep in mind. Middle age, do a Baton score. And then the brachial plexus examination, which is, I think, brachial plexus examination is a gift as well. Okay, people are nervous about the brachial plexus, but I think it's pure anatomy session. It's a pure anatomy session. And then once you do, the anatomy, there is a video in YouTube, how to draw brachial plexus in 10 seconds. Okay, know that video, go to YouTube and find it and know it. Draw your brachial plexus in 10 seconds and before your exam. I did this session particularly for guys who are going in at the end of this month. You need to know the brachial plexus in 10 seconds. You need to see where is this nerve coming from, where is the root, and there is a very nice way of examining. I used to examine the brachial plexus in 1.5. Well, we used to do it 3 minutes, and then at the end, we lower it down to 1.5 minutes. 1.5 minutes, you finish the brachial plexus. and that's it. And the way I use the abbreviation of Hamas, it's H is for Horner syndrome, M for muscle wasting, A for attitude, S for scars, S for splints. The same way I used for all the cases for that, it was mass. Here it's Hamas with Horner syndrome. Okay, this is the way I just when I see something like look like brachial plexus, okay, Horner syndrome, then mass, muscle wasting, attitude, splint, and scars. And then you go for the sensation according to dermatomes. So the dermatomes are very clearly written in Asia, and you need in the Asia paper, you will see there are dots. Okay, so these dots are where is you check the sensation. So you can't say, oh, this is here in this here C5 and this here. No, you go with the dot in the Asia score. So you see here in the lateral condyle is C5. You don't check it here. I know that people that check it here. No, you leave it in the lateral condyle of the humerus, and then for C6, C7, C8, and T1. So these are points that you are shooting on those points. So you don't faff around. And then the motor myotomes are very particular. If you go to the Asia Asia sheet, you will find these are very clearly written, and these are the muscle testing. You are going to do it according to Asia score. So your main aim in the brachial plexus is to find the level. Okay, and then you can take the discussion later. Actually, brachial plexus is really good because you start in high. You start in like the scoring. Once you know this is brachial plexus, you probably add 5 and 6 or 6 actually, knowing the brachial plexus, and then you can go for what type of brachial plexus. Is it upper brachial plexus or lower brachial plexus or total plexopathy? Now, there are an unusual pattern, and this is the one that comes into the exam. So unusual pattern, you need to think of Parsonage-Turner or some brachial plexus with partial treatment, with tendon transfer or something like that. So unusual pattern in the brachial plexus, although you can see the deformity, you can see everything, but there is unusual pattern. So think either this is Parsonage-Turner syndrome or some tendon transfer. These references are, I found it in kind of no particular order, but I prefer this order. Banaskovich is a very good book, okay? You need to read it. You need to read it at least once, okay? It's a good book and it's a good reference and everything is there. It's a big book. I found it really hard, but try to get hold of this book, okay? Mafuli has a very, Nicola Mafuli and Mansour Qasim, this is the book has a very good examination and a very good kind of selection of cases. There is another book by Sharma. I don't think it's I don't know. It's okay by demonstrations and stuff like that, but I think Mafuli and Banaskovich are the best in the market so far.
I think the best thing to take from this Himanshu Sharma book is that he has given you a list of clinical cases and he has narrowed it down to a few examinations that you can do which are specific for that clinical case. Like if you get a helix valgus, what are the 4 things you are going to do? What if you get a cabo varus, what are the 5 things you are going to do? So when you are making your flashcards, that's what Sanjit has been telling you all for the last hour, is that you concentrate on those 4 or 5 things and you do them in an orderly fashion and be very slick with them. And you just kind of zone in on that thing. And that's where you get the marks.
Okay, guys, I have to stop here and thank you very much for listening. If there is any burning questions, you can either raise your hand or you can, we just will unmute you.
All right, thank you very much, Amjad. That was a very nice presentation. You did very well. And I think you've covered all the topics and you've given us a very good
Recording? It's